It is our pleasure to welcome Dr. Naim El-Aswad and Dr. Tom Syzek to present to us today on physician burnout. The floor is yours, doctors.
Thank you, Jenna, for this wonderful introduction. Before we start, it is my privilege and my pleasure to be here. This is a very unique opportunity, and I am thrilled to be a part of the Sullivan Group. I would like to ask of the audience if they have a paper and a pen to keep them handy, because throughout the presentation, we'll be asking some reflective questions and some intriguing questions, so to speak, for them to write down their answers to try to make this as interactive as possible. The learning objectives for today are pretty simple, straightforward. We need you to develop an understanding of malpractice suits and the factors that lead to them. We also need to develop an understanding of physician burnout, identify the relationship between burnout and malpractice, analyze the effect of burnout on physician factors that lead to malpractice suits, identify areas of intervention, and then there are some conclusions and closing thoughts. And please also bear in mind that the audience we have is of a diverse background, so each one of us will view this from their own eyes or through their own lenses. And hopefully this will make sense to all of us with one unique objective, which is to try to tie physician burnout to malpractice suits. Now, before we start, let me start with the definition of what a malpractice suit is. Again, it's pretty straightforward. It's a failure of a professional person, as a physician or a lawyer, to render proper services through reprehensible ignorance or negligence, or through criminal intent, especially when injury or loss follows. I'm highlighting any improper, negligent practice, misconduct, or misuse. Now, why do I highlight that? Because if we just focus on the improper, negligent practice or misconduct or use, I will stop here and ask you if you can think of some of these actions that you label as improper or negligent, whether it's actions or attitudes or behaviors, or even emotional expressions that you have witnessed or that you have been a part of. And just take a minute to write down some of these things that you would consider improper, and these will come in handy later on. So as I am focusing on these, just write down some thoughts that immediately come to mind, 3 or 4 maybe. Now, all of these, whichever you have written down, they all have factors that lead to them. Remember, this is a profession of medicine where we have taken an oath to help people, so something must go wrong for us to become improper and negligent and have a misconduct or misuse. So there are factors there that have led to this, and it is our goal, so to speak, in this presentation is to tell you how these factors lead to it, but more importantly, what is the relationship of those factors to physician burnout, and tie it all together, so to speak. Tom, I'm going to leave the floor for you right now. Take it away.
Great. So as Naim pointed out, burnout results in risk factors that in turn can contribute to malpractice or improper, negligent practice or misconduct. So physicians are not the only source of malpractice risk, as we all know. And we know there's other factors in the hospital, the healthcare system, and other healthcare providers aside from physicians that all have a role in medical errors that lead to suits. Malpractice data we have on the physicians, though, has made us really wonder what's the link, perhaps, between malpractice litigation with burnout? And that's what our talk is about, and we'll go into that in more detail. But so, here's a statistic I always wondered about. Well, 1% of physicians are responsible for almost a third of all suits. That kind of raises the question, what do these physicians have in common, and some common characteristics that perhaps we could look into or researchers could look into to see what the trouble is. The question is, are they typically have poor communication skills? Do they have inadequate knowledge base? Meaning, did they, skip something in med school or residency they should have learned? Or perhaps are they suffering from burnout? And that's really the crux of our talk and focus today. Some other statistics here are that malpractice continues to be pretty pervasive. That is the exposure of physicians to malpractice litigation. The Medscape report, a good source of data, said that 55% of physicians have been sued, and nearly half of them more than once. Over half of the physicians are caught by surprise. They haven't self-identified any perhaps risk factors or reasons why they would be the ones to be caught in a suit. And following a med mal suit or malpractice litigation, I can tell you this changes your life forever. There's a lot of adjustment that goes through, that a physician goes through upon going through malpractice litigation, and their attitude certainly can change towards patients, sometimes for the better, often for the worse. Next slide, thank you. So it turns out that multiple studies have actually demonstrated a link between burnout and medical errors, and proven the association between burnout and malpractice suits. These are all relatively recent, although this one study goes back to 2006, that this has become really well recognized. We used to, think that this is just the physician didn't think of it, they didn't think of the diagnosis, they were perhaps poorly communicating, but now we're realizing that there's an identifiable risk factor for med mal, and that is certainly burnout. And then there's a vicious cycle where med mal suits, which are very stressful in themselves, results in even more burnout, the so-called malpractice burnout syndrome. So let's take a look just real quickly at some of the reasons, common reasons I think that most of us know. We can bring the whole graphic up, that most of us on this call know there's common reasons for physicians are sued. These are allegations we see in the complaint. Failure to diagnose, very common, especially in acute care medicine, such as emergency department. A bad patient injury, patient suffered a bad injury. Failure to treat, we perhaps knew the diagnosis but did not administer the right treatment in a timely fashion. Poor documentation, we forgot to tell or didn't document telling the patient what to do, what not to do, and about their treatment. Medication errors, another category. Then there's system errors, the failure to follow safety procedures, and then at a few percent, informed consent issues. Well, the most important finding of the CRICO study that analyzed thousands of malpractice suits is not these known categories that we kind of already know about, but it's that communication is a factor in 30%, and I would say probably even more, of med mal cases. So what used to be for physicians an optional soft skill, which we used to call bedside manner, communication is really now recognized as an essential tool for healthcare providers. They have to have this ability to deliver safe, accurate, and effective medical care. And the failure to communicate will often lead to adverse patient outcomes, poor understanding by the patients, and eventually perhaps adverse patient outcomes enough to foster med mal suits. So another key link. So why are we talking about this with burnout? Well, burnout impairs the physician's ability to communicate effectively. That's the link. Next slide. So I just, I combed the literature recently about burnout and patient safety. What's the link here? Well, it is a patient safety issue. The intuitions and hunches that we used to have about burnout, they're now being studied and published in the medical literature. Take this study from just a few months ago, and it was a study of studies, what we call a meta-analysis. They pooled data excuse me, from over 47 studies on burnout and the associations with some outcomes such as unsafe care, unprofessional behaviors, and low patient satisfaction. So they found, the authors of this large meta-analysis, they found that burnout is associated with a double increased odds for unsafe care, unprofessional behaviors, and low patient satisfaction. So stop and think about this for just a minute. Burnout itself is now recognized as a huge barrier that thwarts the very core mission and values of our entire healthcare industry. You know, we are here to deliver safe care professionally with professional behavior and achieving high satisfaction. So if burnout is a barrier to even accomplishing those basic core mission and core values, and we really have a problem. And the authors agree. They agree with us as they concluded that burnout jeopardizes patient care, flat out. I mean, that's a strong statement, but that's we're knowing how that's true. And furthermore, that healthcare organizations must invest in physician wellness. I did run across a recent doctors company survey, and they found that 63% of healthcare executives say that physician burnout is a top concern. So this is really an iceberg that more than the tip is now beginning to show. So I'll turn it over back to you, Naim.
Thanks, Tom. I'm going to add to what Tom said and highlight something about physician attitudes. And if I had a flashing neon sign on attitudes, I would put it up there, but this is going to come back later on. But I want you to take a look at the following study to echo what Tom was saying as far as communication. So in April 2013, researchers at a Denver-based communication company, they analyzed over 3,600 online reviews of 300 internists and OBGYNs. Now, it turns out that the number one reason why people are not satisfied with their physician isn't that the physician got the diagnosis wrong, because as you can see, 21.5% of the complaints were about medical skills such as false diagnosis and surgical mistakes. The number one complaint was about poor bedside manner. So as far as the patient is concerned, it doesn't matter. It matters, obviously, that the physician got it wrong, but it's twice as important about how the physician was at their bedside, how they treated them. And this is kind of like stunning, and it hits the physicians in the face that, wait a second, I went through all of this in med school so that I can hone my diagnostic abilities and my clinical skills, and now I'm getting judged not on, oh, I got it right and gave the right treatment, but how did I convey the message? And that's one of the reasons why 58% of physicians are caught by surprise. So if you think about it, almost 2/3 of physicians are oblivious that they are doing something wrong. They just have no clue along whatever axes that can cause the malpractice suit. And that's a pretty large number when you know that we're operating in the blind and not expecting this. So let me ask you this. How many of you are burnt out? Further, how many of you know someone who is burnt out? And if you do, what do you think it is? Now, as you ponder this question, we talked about the factors that are affecting the malpractice suits. And so to summarize them, it's communication, communication, communication. Then there's the professionalism, which is the attitude, accountability, appearance, demeanor, reliability, ethics, competence, maintaining poise, organizational skills, interpersonal skills, part of which is communication, diagnostic abilities, part of which is competence, clinical skills, and documentation. Now, every single one of them is a lecture on its own as far as its connection to burnout. But it is astounding that the literature has found that burnout affects each and every one of these factors. And I don't know of any other condition that will do that. So what is the tie now between physician burnout, and why does it cause, or does it have such a pervasive effect on all of the factors that will lead to malpractice suits? So what is burnout? We've been talking about it, but by definition, there are several definitions. We borrow from the most common one. And burnout is defined as feelings of lack of personal development, becoming cynical, loss of empathy, and a gradual erosion of enthusiasm for work. Now, 3 minutes ago, I asked you if you are burnt out or know anybody who's burnt out. If you look at these symptoms, do you consider yourself burnt out? And do you know people who are cynical, who have lost their empathy, who have feelings of lack of personal development? And then I told you about the attitudes and highlighting it neon lights, because attitudes are contagious. And if you look at the picture, mine might kill you. And why do we say that about burnout? You'll see in a few slides. Now, whatever the causes for burnout, Christina Maslach, from the one who wrote the book on burnout and developed the Maslach burnout inventory, says whatever the causes for burnout, they fall under three main categories. They're unmet expectations. I didn't sign up for this. This is not what I expected. Lack of control, another thing shoved down our throat to do before we actually see the patient, or we're told what to do, what metric to follow. And then insufficient rewards. And that's a whole different topic on its own. But we went into medicine and the practice to help patients. And then gradually we are looking towards other metrics than helping, and therefore we create the insufficient rewards cycle. And then in 2016, Shanafelt, who's one of the gurus on physician burnout, said, you know what, let's add one thing to that. Let's add leadership. And you've heard of the phrase, people quit their bosses, not their jobs. Leadership is one of the main causes of burnout. And if you take one step back and say, all right, what in my organization, or where, or who, or when would these apply to my physicians? And as I go through the factors, if you will, you can identify them more. Now, how many of the physicians are burnt out? Well, if you look at the literature, this is from 2014 or 15, but the new one from Medscape came out 3 days ago, and it's pretty similar, plus or minus 1 or 2%. So you see that the range is anywhere between 37% for dermatologists all the way up to 53% for critical care. On average, 50% of physicians are burnt out. I say that now. I wanted to let it sink that 1 out of 2 physicians that are practicing or that you are insuring is burnt out. Now, this is not just data in the US. This is international data. 67% of female physicians are burnt out. 44% of male physicians are burnt out. Now, how severe is physician burnout? Well, on a scale of 0 to 5, on average, you're going to be about 4.2. Now, why is that important? Well, again, depending on the specialty. But you can see how close they're clustered together. So the difference is really 0.7 in total, which is not much. So pick any specialty, and the risk of burnout is 1 in 2, and the severity is 4.2 out of 5. Well, what does that mean? What does 4.2 out of 5 mean? How do we compute that? How do we, what's the quantitative data behind it? In our book, we talked about burnout and we likened it to a malignancy. Why? Well, what does a cancer need to grow? First, it depends on environmental and genetic factors. So does burnout. Environmental factors, things outside our control, versus genetic factors, who we are. Then it needs time. It is a cumulative effect, a negative cumulative effect. We start from medical school, half of medical students are burnt out. During training, half of them are burnt out. As they graduate, half of them are burnt out, and it continues so on and so forth, but the levels increase. And finally, we lack defenses and the ability to detect. That's why it caught so many physicians by surprise. It isn't that just 58% were caught surprised by the lawsuit. It's more even have been caught by surprise that, wait a second, I'm burnt out? Now, I asked you first to kind of think about what do you think the manifestations would be. So on a professional level, here's what happens. Burnt out physicians have poor judgment in patient care decision making. Now, as I say these, tie it just to the malpractice issues, more so than anything else, because that's the focus of today. Hostility towards patients. and think about how that affects medical errors, adverse patient events, diminished commitment and dedication to productive, safe, and optimal patient care, difficult relationships with coworkers and disengagement. If there was ever a poster child for what to do wrong to get sued, this would be it. On a personal level, there's depression, there's anxiety, sleep disturbances and fatigue, and again, picture the physician coming to work with one of these personal problems. Broken relationships, alcohol and drug addictions, the drug of choice usually is marijuana, marital dysfunction and divorce, early retirement, and suicide. And to highlight burnout, the rate of suicide of physicians just from burnout is about a physician a day. It's anywhere between 350 to 400 physicians per year kill themselves because of burnout. So much so that OSHA says that practicing medicine is one of the top 5 most dangerous professions. Not work, that's for lumberjacks and people who work high wire electricity. Professions, one of the top 5. So if you think about it, practicing medicine is one of the highest, riskiest professions. And it causes one physician to kill himself or herself per day. This is staggering. Now, again, if you wrote down everything as far as what you think can cause and the link to burnout, let me review it real quick. So malpractice suits, they happen because of attitudes, communication, inadequate diagnosis, surgical error, anesthesia errors, failure to obtain informed consent, infections, medication errors, and healthcare worker fatigue. So we have kind of summarized everything you probably already know when it comes to malpractice suits and the causes, and now we've introduced burnout and what it does to the physician. But let me take it a step further to really cement what happens. If you look at the physician, what defines the physician? Well, there are many definitions, but I like Martin Fisher's definition. He says observation, reason, human understanding, and courage. These make the physician. Now, what happens to a burnt out physician? Well, what happens to their sense of observation or the power of observation? They become disconnected, unrealistic, can't read clues, and are checked out. Can you think about situations where this affects factors that lead to malpractice suits? What kind of factors do you think, or can you name 3 or 4 of them, where being disconnected and unrealistic has a direct effect on the factors that we have talked about to cause a malpractice suit? So just take 30 seconds to think about some of those factors. What I will list is a few. This is not an inclusive list. But if you answered professionalism, clinical and diagnostic skills are affected, then you're right. So let's go to reason. Decreased ability to analyze, assess, and think. Loss of clinical skills and abilities. Again, if you take about 30 seconds, where do you think that affects? I mean, the last thing you want to hear is a surgeon go, oops. But that's what happens. Why? So if you've answered clinical and diagnostic skills, documentation, professionalism, you're right. Now let's go into human understanding. Can't understand or relate to others, loss of empathy. Where do you think that's going to have the most impact? I think there's a collective agreement on communication, professionalism, and interpersonal skills. And finally, courage, where we become distant, insecure, blaming others, explosive, unpredictable, and aggressive. professionalism, empathy, and documentation. And these are just, like I said, they're not an all-encompassing list, but you can see now the relationship of burnout, hopefully, how it affects the physician, and then how the physician, when affected, leads to malpractice suits. Now, let me highlight something else, which we've mentioned. Half of the physicians are burnt out at a 4.2 out of 5 severity. I told you I'd try to explain what 4.2 out of 5 means. So in terms of malignancies, we stage cancers 1, 2A, 2B, 3A, 3B, and 4, 4 being the end stage metastatic. So if you're going to stage burnout, it would probably be at about a stage 3B, one shy of metastatic disease. So let this sink in. 1 out of every 2 physicians is burnt out, has that malignancy at a stage 3B, and they're the ones that are practicing out there, and they're the ones that are in trouble. By default, of course, I'm talking not just about them, but about the patients. And then just think how that reverberates and how that affects malpractice. Now, there's a uniqueness to burnout, and we talk about the pendulum. See, psychologists talk always about pendulums and how we sway every day, or, from being too happy to too sad, and somewhere in between, that's how our day goes. Burnout is no different. And the highlight and uniqueness of burnout is it's a contagious, malignant existence that sways between minimal to extreme. It's contagious. Attitudes are contagious. Mine will kill you. This is a contagious. Everyone go into a room where you're happy and everybody's down or angry, and they suck the life out of you. They'll look at you and say, "What are you smiling for?" And then you all of a sudden just drop down. Or vice versa. You're down, you go in, there's a group of people who are happy, elated, laughing. They'll lift you up. So a burnt out physician has a contagious existence that reverberates along with other peers. And if you're considering 10 physicians and 5 of them are burnt out, well, you can do the math. That pendulum is pushed by personal, professional, emotional, psychosocial, and environmental factors. The good days, the bad days, and everything that goes in between, that's what pushes the pendulum. And finally, it is the only disease or condition that has extreme morbidity and mortality consequences on physicians and patient alike. So if I'm a physician who's burnt out at a rate of 4.2 out of 5, and I go and walk into a patient's room, the chances of me harming that patient are so high. I'm going to give you an example of somebody who just had a transplant, a bone marrow transplant, and they're in the isolation unit, and they have absolutely no immune system. And then you walk in as a physician, and you've got tuberculosis, you're coughing in their face, you've got the flu, you've got pneumonia, you've got the hepatitis C, HIV, your blood gets into theirs, and then, and strep pneumo, and then you walk out the door, the patient will die within 3 to 6 hours. That's how bad burnout is. And that's why there's a big hoopla and an awareness now that's increasing. So all physicians, they train to have 6 HCGME competencies: and professionalism, interpersonal communication skills, medical knowledge, practice-based learning and development, patient care, and system-based practice. I'm going to highlight interpersonal and communication skills and give you an example of what happens in burnt out physicians. So burnt out physicians, 7% of doctors encourage patient ideas or suggestions, which means 93% of burnt out physicians really don't want to hear their patients. It's astounding. Just start putting those numbers together. Patients are interrupted a mean of 18 seconds after beginning to speak. I'll know from the emergency room, you'll walk in, so tell me what brings you into the hospital. And then within 18 seconds, if they still haven't given you the answer that you look for, you'll interrupt them. It's called the 18-second rule. And I'm sorry, if the picture down there is not very clear, it's the patient telling the physician, "Let me know if you want to know why I am here." Once interrupted, only 1 in 51 patients added additional concerns. So 93% of burnt out physicians, half of the physicians, right? 93% do not encourage ideas or suggestions. They interrupt their patients at a rate of 18 seconds after beginning to speak. Once interrupted, 1 in 51 patients will add additional concerns, which means 50 patients will not. The number one reason where we diagnose people, or how we diagnose it, is H&P, history and physical. So 50 patients out of 51 won't give you the full history. Communication breakdowns are responsible for 85% of sentinel events in the hospital, meaning, well, the patient never told me that. Why didn't you address the patient's chest pain? Well, they came in for abdominal pain. They never told me chest pain. Or I didn't communicate it to the nurse, or vice versa. Diagnostic errors are frequent with breakdown in communication, 10 to 15% rate, and are the leading cause of malpractice claims because of communication. And this is only one of the ACGME competencies that burnout affects. If you take all of them, just think about from the professional standpoint how many mistakes and adverse outcomes. From the medical knowledge, from the patient practice-based learning and development, from patient care system-based practice. I'm hammering this point in because it hit us all like a boulder. And to add to it, 2/3 of the physicians are oblivious to this happening, being sued, and even more are oblivious to them being burnt out. Best example I can give is 1984, when we first came up with the diagnosis of Kaposi sarcoma, pneumocystis carinii. We had no idea what was happening. It took us 4 or 5 years to call it HIV and AIDS. We just recognized the symptoms and knew something was wrong. Now, with all of this, what can we do? What are some options out there that we can do? Obviously, we don't have time to go into all of it. So these are all bullet points for people to think of and try to kind of personalize it for their own institution or themselves. So the approach to burnout, you can either tackle what is known as the antecedent factors, everything that leads to burnout, and I'll talk about them just a little bit. But these are extremely complicated and take years to develop. And in my conversations with all of the accreditation bodies and all of the government bodies, National Academy of Sciences, the ACGME, the AMA, they all believe that 80% of burnout is because of these factors, whether it's EMRs or systems in place, institutional, governmental, but they all acknowledge that it's going to take years to effect it. So great, wonderful. What about now? What about the physicians now? What about those killing themselves? What about all of the patients? What happens now? And their overwhelming response is, and I kid you not, is we'll get back to you because we don't have an answer. Over the past 5 years, this is what we have been doing. We've taken the physician and the healthcare provider and kind of changed life to them from what happens to them to what they make happen. Meaning, if this is what's their environment, how can we help the physician and the person absorb and deal with their environment? And so what are the causes, if you will? And again, this is internist burnout, but this is everybody's burnout. And the newer slide from Medscape's report 3 days ago is about the same thing. So too many bureaucratic tasks, that's number one. Spending too many hours at work, income not high enough, feeling just like a cog in a wheel, increasing computerization of practice. And as I go through this is what I need you to kind of visualize to say, okay, what can I do in my own institution or my own group, or as a physician, what can I do to help at least my physicians? I can do something right now. Too many difficult patients, too many patient appointments in a day, the impact of the Affordable Care Act, EMRs, difficult colleagues or staff, difficult employer. And they will all fall under those 3 main things that Christina Maslach talked about: unmet expectations, lack of control, and insufficient rewards, and then leadership. On an organizational level, again, Shanafelt, about 2 years ago, maybe a year and a half ago, came up with wonderful 9 steps that each organization can take to help mitigate burnout. So this is acknowledge and assess the problem, harness the power of leadership. There we go, leadership again. Develop and implement targeted interventions. Facilitate and fund organizational science, meaning what can we do within our organization to help. Use rewards and incentives wisely. Align values and strengthen culture. And by the way, culture trumps strategy anytime. So if you have the proper culture, you're way ahead of the curve. Promote flexibility and work-life integration. Provide resources to promote resilience and self-care. Cultivate community at work. What that ends up doing is it increases loyalty, happiness, less turnover, increased production, less burnout, better leadership, less problematic MDs, better outcomes, and patient satisfaction. All of this, which obviously will lead to less malpractice suits. They came up with their WellMD Center in Stanford. Last year, in 2017, they had their first AMA/Stanford/Mayo Clinic symposium, workshop, or conference on physician well-being, which is now a big thing, and they came up with 3 things that are very important for every organization: to have a culture of wellness, an efficiency of practice, and personal resilience for professional fulfillment. Now, again, they go through every one of them and what they entail, but I'm just highlighting them here. On an individual level, again, if you only focus on the problem, you might miss the easy solution. So what we did is we took people, and not just us, obviously, there are other folks out there who are doing the same thing. And we know from literature that this is what also helps. Individual targeted approaches, focused small group discussions, providing physicians with some degree of choice and autonomy, building camaraderie, opportunity for excellence, developing physician leadership, culture change within the institution, coaching, resilience development training, emotional intelligence, and self-care. Recurrent themes, at an individual level or at an institutional level. And we know from personal experience and from the literature that this is what works. Some practical tips on an institutional level. First and foremost, identify a champion. Somebody has to adopt the project. A leader for the cause needs to be there. If you don't have someone who's going to adopt the project, it's not going to work. It's going to be lost. Then identify the needs. Do a survey. Do you have physicians who are burnt out? Are your physicians happy, or nurses or staff? Outline your goals. Once you get your surveys back, so what are our goals? If the physicians are so burnt out, like 90% of our physicians are depressed and burnt out, that's one goal, versus 10%, that's a different goal. Develop an action plan based on your surveys and your goals and the guidelines. Identify your resources. Okay, great. We need to do this and that, but what are our resources? What's our funding? What's our physical place? Where can we create a room for physicians to connect, for example? Assess and reevaluate. Set a timeline for your intervention. And then it started with the assessment first and then the assessment at the end, and see how it worked. And then fine tune and commit. That's the organizational science and funding. And finally, involve management. You're not going to be able to do anything if there's not no money in it and management is not involved. This is a synopsis, a very brief synopsis for a very powerful topic. This is over like a 30,000-foot view on physician burnout. It is very prevalent. It is very toxic. It is very dangerous. And it will probably be the leading cause for malpractice suits, given every factor that it affects. So the question now is, when do we intervene? And I guess you all agree that the time is now. I'm going to flip it now to Tom so he can summarize everything and give you a different perspective. Tom, take it away.
Great. Thanks, Naim. There's just really so much to be aware of, learn. There's great resources for this, not only publications such as your own book, but medical literature, the common medical literature that's coming out and making these links. And then I think beyond awareness and acknowledgement is, how to design interventions or solutions to begin to tackle this. And then that's the hard part. And we are, there's strides being made and varying solutions that can work, that need to be tailored and individualized for each physician, for each physician group, whatever organization employs the physicians, and of course hospitals that have by nature their large medical staffs. So in summary, just related to malpractice and insurance, we all know and agree that the toll for malpractice suits is huge in so many ways. It affects, obviously, patients who are affected and then get into malpractice litigation industry. Physicians, definitely the target of and affected by suits based on the statistics we talked about before. Not just physicians, but other healthcare providers. If you don't employ any physicians, but at a hospital or institution, where of course you do employ the nurses and everyone else, they're often a part of this and certainly affected by it. The healthcare industry as a whole is affected by medical errors and the resultant legal actions that can take place, claims, suits, and incidents, both in the hitting the industry in cost, delivery, and availability, and the quality. And I would say the quality of the delivery and availability, as so much time, effort, and expense is spent in managing the damage and the carnage that occurs after medical malpractice litigation. So next slide. And so finally, physician burnout has a major impact, as we know, on communication and medical errors. This brought it home with the great points made by Naim. And it's really one of the most important contributors to malpractice litigation. I'd say we really didn't think about this or term it this way as recently as 10 years ago. We had other terms for what these failures to diagnose, failures to treat, and kind of a different taxonomy. But now I think we need to look deeper and see what is going on behind the scenes related to physicians. As I used to give risk management lectures, I used to always tell our physicians, probably the number one thing you need to think about is before you come to work, and this goes for nurses and all other healthcare providers, you need to empty your baggage, you need to leave it at home, you need to bring your A game. Because if you are affected by burnout or other issues, just lack of sleep, alcohol and drug issues, then you're bringing that into the workplace where you're entrusted with a huge responsibility and duty to deliver the best patient care with the greatest satisfaction you can, and getting it right as often as you can. So that was a simple thing I used to say, is just bring your A game, okay? Get enough sleep. Don't be out all night. Just simple tips, but a little did I realize that it basically fits right into where I was just unknowingly addressing the very tip of the iceberg, that perhaps some of those behaviors in that physicians and healthcare providers bring to work that are maladaptive are part of burnout. And now we can go back a step further and even analyze this burnout. So to start with, we all need to recognize and acknowledge that half of physicians suffer from burnout. Let's just get that up front. And once we're aware, we then need to take action with interventions, some of which Naim outlined, that target burnout not only to improve the physician well-being. This is a great benefit, I think, for the physician and healthcare provider for their own well-being, physical, emotional, spiritual, mental well-being, but also really to take action to mitigate the impact of burnout on medical errors, on patient safety, and our entire healthcare system. So this really is rising to the level of a duty of all of us involved to be involved. These interventions need to take place not only at the individual level, but also at organizational, institutional levels as much as possible. And again, that was really emphasized quite well by Naim. So at this point, just a quick thank you for your attention and interest in this important topic. And I will turn it back over to Jenna to moderate any questions that you might have that Naim or I could help answer. So thanks again, and Jenna, I'll turn it back to you.
Great, thank you, Tom and Naim. I have had a few questions already come in, but if you do still have a question for Tom or Naim, please enter it in the chat or questions box, and we'd be happy to address those with the time we have remaining today. So first, the question that we had come in here asks about, from a risk management standpoint, are there clear signs to look for in our physicians that will direct us to identifying the conditions?
Well, Naim, why don't I take a quick stab at that, and you'll probably add something to it. But in a list of the outcomes or the signs or symptoms of burnout, I think that's the key. And so some of the signs to look for are, say, from an institutional side, if you notice a particular physician is getting increasing number of complaints or incidents, this doesn't necessarily mean they're burned out or that they're doing anything wrong, but it is a metric I think that perhaps deserves a little deeper look. So complaints or incidents from patients or peers, trend of increasing peer review incidents, perhaps, and then on a macro level, again, not a one-to-one association, but again, just something to look at, the number of incidents, claims, and suits. Other clear signs, as elaborated on by Naim, would be their own behavior. I mean, if you know these physicians well enough, work with them day to day, are you noticing as a friend, as a colleague, signs of depression, anxiety, sleep deprivation, alcohol or drug issues, or marital problems? These are all potential manifestations of burnout or events in their life that can expand burnout. Naim, anything else on that one?
No, I think you hit every nail on the head with that one. It's summarized it wonderfully, but I will highlight that what Tom said is not all of these will come from burnout. Sometimes it's just people are going through a stressful thing that has nothing to do with them being burnt out. But yes, this is pretty much what Tom has summarized wonderfully. That's what you look for.
Great, thank you both. As a follow-up to that, I think this plays nicely. The question is, what are some of the best ways to approach someone who you believe is burned out?
That's a great question. Well, the first thing is, once you identify that a person might be burnt out, and it depends on the level in the hospital, depends on how the systems work. Sometimes, like in the emergency room, you have a medical director. So the way whether it's nurses or physicians, obviously we're talking about the first person to notice would probably be friends and their director. And so it becomes a conversation, usually initially, of observation, and then sitting down with that person and in an indirect way try to kind of either have them understand that they might be doing something wrong, or just asking some probing questions. In a very, of course, this depends on the person, but in a very subtle way, to bring to light some of the things that are now considered abnormal by that person's standard. Meaning, supposing they never are late, but now, hey, I've noticed for the past few weeks you've been showing up late. Everything's okay, or your charts are not done the way they used to be. Are you okay? Some of these things gradually will lead. Some of these probing questions will lead into the discovery, so to speak. Again, there are different levels of interventions. The bigger the offense, sometimes the more intense the approach. But it's always, especially in the field of medicine, nice to start slowly with probing questions and work yourself gradually up.
Right. And I would just add to that the leadership can start by creating a culture in which the topic of burnout or provider wellness, nurse wellness, you name it, is discussed, from the employer standpoint, from the colleague standpoint, that these are things we are concerned about. We're concerned about wellness. We're concerned about burnout, and just throwing it out there as this is now allowable area to discuss, giving permission to your med staff, your nursing staff, etc., not in a blaming fashion, but more like incident reporting, almost rewarding people for bringing up, perhaps their own problem or awareness. But then I think the way to approach it, I would think, is privately, if you know that person, let them know it's a concern for them. Don't make any conclusions. It's more open-ended question. I've noticed this. It seems like you're pretty angry. It seems, whatever you've noticed, say, I'm concerned about you. Happy to talk to you about it more if this ever becomes a problem. Plant the seed for openness, that they won't feel so isolated, they won't feel so ashamed, that there's a way that they can not be viewed as a personal failure and still get these issues addressed.
It's a great point, Tom, that you raised, because one of the things that physicians and nurses they all fear, obviously we're all always scrutinized and under the microscope, and the last thing they want to know is that, oh, hey, I have to now also be observed for these behaviors. It's already the fact that the physician-patient relationship is the most scrutinized relationship in the history of man. So one of the things is to come at it from a positive standpoint, not a Gestapo standpoint where I will tell on you if you do this. It's no, let's come together, let's build a positive attitude, supportive environment, and talk about it, because burnout has its own language. So if you prep everybody saying, hey, you know what, this affects all of us, let's share some stories, let's do this, these are some of the things we'll be looking for, and plant the culture, it becomes that much easier to approach and that much easier for people to talk about it.
Fantastic. Thank you for all those ideas. Our final question today will be from the organizational standpoint. What are some of the strongest challenges that we face in implementing programs to address burnout?
From our own experience, it's organizational dependent and physician dependent or nurse dependent. From the organizational side, it's lack of awareness, A. B, it's cost. I had a conversation with a CEO 3 years ago about doing a program for their physicians, and the CEO's response was, can we afford to know how many are burnt out? Because they didn't want to get into the topic of burnout. So my answer was, well, you can afford not to know. So people perceive the C-levels, managers, everybody, they're still waiting on the ROI, return of investment, on actually doing something for physicians or nurses, because that requires deviating from the norm, the way medicine is practiced now, and instituting some things that are new, which obviously they're not in the system, which means that they're going to cost money. So that is the other thing. And then burnout has its own language, and people just don't understand it. You say burnout, like, oh, depressed, anxious, what do they have? I mean, what is it? So is it what, they're not happy? Do I pay them more? Do I pay them less? What do I do? So there's lack of awareness. And then like with everything, there's resistance to change. From the individual standpoint, number one thing is shame. Physicians and or nurses do not want to admit that they're burnt out. And again, there's lack of awareness. We didn't know these symptoms or signs are those of burnout, but now that we do, I'm not going to be the first person to ask for help. Our whole culture is predicated on, if you're not strong enough, you're not cut out for it, get out. Which means you have to be Superman or Superwoman and do everything that you've been told, and you have to share stories of how you, as an intern or resident, didn't sleep for 75 hours straight while working and did a wonderful job. So there's a culture change there, and it starts in the schools and residencies. And then there's that physicians are pretty resistant, as well as nurses, to their own well-being and self-care. Just ask anybody who is in the healthcare business or industry who becomes a patient. So there are a lot of obstacles that can be navigated. Part of it is because of the newness of the diagnosis, and the other part is because we're oblivious to that system. And these are easily changed. They just require a little bit of time and dedication.
And I don't have anything to add to that, Jenna. That was a great answer and insight. Thank you, Naim.
Thank you both for having me on this wonderful presentation. It's really a privilege, and it was my absolute pleasure to be here.
Well, with that, thank you both for all of your insights on physician burnout today. A reminder that today's call was recorded, and so we will send this out via email by early next week. So you can either review this again or feel free to share it with your colleagues. It's a very important topic we all need to make sure we are aware of. So with that, if you have any questions about the Sullivan Group or our relationship with AXA XL, you can contact your broker, or you can chat with Brant Roth. His email is listed here. So with that, thank you everyone for your time today. We greatly appreciate it, and we hope you enjoy the rest of your afternoon. Have a great day.